Welcome to this interview with John Sharkey for the Surgery and Therapy Summit. John has 40 years experience as a clinical anatomist, and he's a recognized authority in the field of medical anatomy, physiology, fascia science, and the treatment of chronic pain pathologies. With postgraduate qualifications as an exercise physiologist and manual therapist, John has worked with Olympic-level athletes in his role as member of the Olympic Council of Ireland's medical and science team and as senior tutor on the master's degree in neuromuscular therapy accredited by University of Chester. John is the author of several books ranging in topics from anatomy, fascia, chronic pain treatment, fibromyalgia, as well as contributing to Travel and Simon's Myofascial Pain and Dysfunction, the Trigger Point Manual, 3rd edition. John, it is an absolute honor to have you at the summit, and we look forward to this interview so we can learn more about you.
Thanks very much, Robyn. It always seems strange when you hear 40 years experience. I've no idea where the years have gone. It really, they've flown past. But it's great to be here. It's great to be talking to you. Let's get to
it. There's so much that we want to learn. John, tell us a little bit about your career. What made you decide that you wanted to become a clinical anatomist?
Oh, wow. That starts back in the early 70s, I think, that as kids, first of all, I was very much influenced by Star Trek and Captain James T. Kirk of the Starship Enterprise. Carl Sagan, of course, with Cosmos. And we were encouraged as kids to look up to the sky and to think big. And of course, John F. Kennedy's famous speech about sending a man to the moon. All of those things influenced us kids of the 60s, and I was one of them. And then in 1979, I participated in my first degree, which was a degree in exercise physiology, and we had a module in anatomy, in dissection and anatomy. And anatomy was just it's just my love. And I understand and I realize that there are limitations and restrictions regarding dissection, but it's also incredibly informative. And then over the years, Robyn, to be honest with you, I've just been in the right place at the right time, perhaps, having met Dr. Leon Chatow in 1984, and myself and Leon built a friendship and a professional relationship, and that got me into the editorial board of the Journal of Bodywork and Movement Therapy. Dr. David Simons from Travell and Simons was my mentor, and he wrote the foreword to my first book. And so I'm very proud of having contributed to the latest edition. A funny little story is that, of course, David has passed now, but David was working on the 3rd edition of the Myofascial Pain and Dysfunction manuals. But unfortunately, he got interested in global warming and climate change. And so he started to write a book on that topic. And that's why he never got the 3rd edition finished. And boy, was he right. So that's, and I've just been involved in bodywork and bodywork therapy, massage and neuromuscular therapy and anatomy. It's just been part of my makeup, part of my fabric.
But I think also what makes you so special and different is that you have kept in touch with the living body and working as and teaching massage therapists and exercise physiology, and just being in touch with that, the fascia and the skin under your hands, and being able to intuitively feel and palpate and understand the human body. I mean, it's so much more than just understanding your anatomy and being an anatomist.
No, I agree with you completely. I mean, there's lots of ways you could describe your hands. They are, intelligent extensions of your consciousness, of your brain. And it's like anything in life that's worthwhile. It takes time. I mean, there are people who come to that quicker than others, but generally speaking, it takes time to be able to build up your palpatory excellence. But when I place my hands on tissues, the moment I place my hands on tissues, there is a communication. there is a conversation that is taking place. And experience allows you to be able to take in information at the subconscious level. I often use the analogy of a piano player. And when a person is learning to play a piano, they will hit some bum notes, and they're reading the music sheet and they're getting things slightly wrong. You come back 15, 20 years later to meet that person again, they're playing the piano, they're looking over at somebody and going, you know, having conversations, there's stuff going on, and they're not dropping a note. They could stick their foot up on that piano and they'd make it sound fantastic. And that's kind of what, that's a nice analogy for me, because as you build your palpatory skills, coupled with visual and auditory skills, in other words, that you're able to look at somebody and, you know, you're able to body read, you're able to look at the skin and the tonus, you're able to listen to vocal tonation. There's so much that the information that you can take in and that tells you about this specific person's situation. And so it's not just one thing, but of course, palpation and touch are absolutely essential. But then, Robyn, people would say things like, if I talk about touching tissue and say, oh, that tissue feels somewhat fibrotic, then they need to know, well, what do you mean by fibrotic, John? And what does fibrosis feel like? And that's where language and vocabulary are also incredibly important, so that you can actually, first of all, you say, well, what does it feel like to you? And then you hear people using terms like bubble wrap, you know, that sort of thing beneath the skin. And of course, in dissection, we were talking off camera before we did the interview just a little bit about myofascial trigger points. And of course, myofascial trigger points disappear in the cadaver. We might come back to talk about them in a minute. But of course, to be able to have the palpation skills to be able to feel and locate the myofascial trigger point. Now, there's an interesting one, Robyn. When I wrote my first book, keeping in mind that I'm a clinical anatomist, but I'm also a physiologist, and I had discussions with David Simons, Dr. Simons, and he did not, by the way, give up on something easy. You had to really argue your point with him. And I was basically saying that really the X's marking the identification of the myofascial trigger points were not helpful. Now, I would say that Dr. Janet Travell was using the X's because she was working with doctors, and unfortunately their anatomy was not particularly good. And so really the X was to help them to mark, you know, where would you typically find a myofascial trigger point? Well, unfortunately, and they were using where the nerve meets the muscle fiber, the neuromuscular junction. Well, neuromuscular junctions can differ from one human being to the next. That's point number one. And point number two is that myofascial trigger points can actually form in any of the millions and millions of muscle fibers. So you have to have the skill to be able to palpate and to be able to identify and recognize myofascial trigger points. And myofascial trigger points are incredibly small. They're microscopic because they form within the sarcomeres. So you would never feel a myofascial trigger point. What you're actually feeling is a cluster of myofascial trigger points, a cluster of them. So each time that you're treating what people refer to as a myofascial trigger point, you are in fact treating clusters of them. And that's one of the reasons why in my book, I recommend that we treat no more than a minimum, well, 3, but a maximum of 5. Because let's just say, for instance, you've treated 5 muscles, that could be 500 myofascial trigger points that you've just treated. And that's a lot. And people have to have the energy and the capacity to be able to then integrate whatever changes that we've instigated. They have to be able to integrate those changes through the entire body. And that requires energy. So what we don't want to do, and what we want to avoid, is we want to avoid ensuring that our patients don't take a step backward. We want to make sure that they're moving forward all the time. So in that regard, less is more.
And also, you might have an immediate change, but for how long is that lasting? You know, you might think, oh, I'm so amazing. I've just been able to take pain away instantly. But as you say, that body's going to walk away from you and going to be adapting and integrating so much, particularly with the energy fields. And
Yeah.
that takes experience to know that what you're having long-term impact.
Well, that's great that you say that. That's a great comment leading into, I suppose, looking for a response. So what I say is, what I teach basically is temporal medicine. It's not spatial, although of course there's time and space, but really it's not about spatial medicine. It's not on a hierarchical basis. On a hierarchical basis, it's about temporality. It's about time. So when you have a unresolved problem in the human body, an unresolved insult, that can, start out pretty innocuous and then it becomes painful. And the longer it's in the system, what it's actually doing now, I'm not going to do a great service to this because within the time frame that we have, I want to try to, be as clear as I can, but we're going to have to reduce things down. So what happens basically over a period of time is that cells that are responsible for inhibiting or tuning down pain, they actually suffer death. They're called glial cells, and they actually suffer death, which basically means that the longer this problem is in the system, then people are losing that inhibitory ability, and therefore the pain is amplified. Mm-hmm. Now, I say that because depending on the individual circumstances, it's not always easy to switch off the pain. But generally speaking, you can switch off pain, and you can switch off pain in the short term. But as you rightly say, that does not mean to say that you have resolved the issue. And, Professor Lorimer Wolseley from Australia, he uses the expression that pain is the brain's way of saying, stop that. I think that's a great expression. Somebody has an injury to their ankle or to the foot, they go to place it on the ground and the brain says, stop that. And, so you don't move. It retards you or it inhibits you. And that can be useful because if you've got an injury there, if you've got some type of serious problem there, you don't want to walk and run on it and make it worse. Well, but sorry, go ahead.
Sorry to interrupt you, but I think I'm passionate about this point that I'm going to make, is that's why I'm very against cortisone injections, because when I work with a hand that is in pain or a tendonitis, I want to work with the pain. If you remove that pain with a steroid injection, you're unable to know and have that feedback to see that if you're being effective. And also our treatment has that healing potential. So you want that patient to go through that process, to have that healing take place with us receiving that feedback and then potentially healing that patient so that they don't need to go on to having 2 or 3 more injections or even surgery. I just wanted to know your thoughts on that.
No, I'm on board with you with that. I think that there are 2 major influences with regards to the use of steroids. And of course, they became particularly popular in the 70s. And from my point of view, from my experience, I see that coming in from the sport side of things. In other words, that whatever sport people were involved in, they wanted to get to the next game and get through the next game. And so therefore was this short-term vision. So we'll do spot injections into the shoulder, and of course these corticosteroids would remove pain. Yeah, that in itself can be a problem because now the feedback mechanism has been disturbed, and you're going out, especially in sport, you're going out and operating at high intensity levels. So what's that doing to the already established insult or injury in the body? Because you haven't got that feedback mechanism. Secondly, I think what many people do not appreciate or understand is that corticosteroids are scavengers. So what's happening basically is the doctor, the medical practitioner, is injecting spot injections. In your shoulder, you could have 17 sites. And the idea is that they're trying to break down scarred tissue or densified tissue. And the idea also would be that they use just enough that that they can return the tissue to some type of normal range of motion. Now, corticosteroids cannot differentiate between normal healthy tissue and fibrosed or scar tissue. So what it's doing, as I say, it's a scavenger. And that's hence why they can only give so many injections, because eventually they're running out of tissue. So really, I think it's quite useful if we can have the feedback from patients. And I think also that there has been somewhat of a culture of instantaneous relief. People are looking for instantaneous release. And what I would say to people is that, generally speaking, there are times when that can happen, by the way, with manual hands-on bodywork therapy. But really, people need to be a little bit more patient. And I can understand that when you're in severe pain, you want it switched off. And yes, certain opioid interventions can be useful. The problem we have, of course, is that we now have complete and utter opioid abuse in North America, in South Africa, in Australia, in Europe. I mean, it's an absolute pandemic. So, we have to do something. And of course, we have empathy for somebody that's in pain. But what people perhaps do not realize is that manual therapists who are knowledgeable can have such a significant impact on reducing pain and providing their patients with strategies so that they can help to manage those pain problems. And remember, the point I'm making is that it takes time to get you back to, living a healthy life with good range of motion and being pain-free. Unfortunately, people are looking for that instant relief. That's what we're all about in the modern era. And I think we need to rethink that situation.
Yeah, absolutely. And again, going back to the clinician, and what you've specialized in as well is having a systematic approach to assessing that tissue. Can you tell us a little bit more about that? Okay,
so, and again, this has taken many, many years to be able to, put a framework in place to be able to then pass on to other therapists so that they can integrate it within their clinical practice, regardless of their stripe. It doesn't matter whether you are, an osteopath, a physiotherapist, a chiropractor, a neuromuscular therapist, structural integrator. It really doesn't matter. I provide these philosophies and ethos and interventions for absolutely everybody. But the first thing you have to do is you have to really pay attention to the actual person that's in front of you. So I refer to it as being a conscious assessment. In other words, you have to really be there. You have to be in the moment. You have to appreciate and understand the individual that is in front of you. And it is so hard, one, not to jump to conclusions very quickly. Don't jump to conclusions is what I would say. That's number one. And number two, there isn't a one fits all. You're going to do, three METs, or, you're going to do a bit of effleurage and it really doesn't work that way. So you have to listen to the person's story. And then I have particular strategies which I teach people that will help them to be able to work out, for example, whether an insult is ascending in the body or whether it is descending. So there is hierarchy in the human body when it comes to things like physiology and metabolism, etc. There's hierarchy. If we suddenly heard an unexpected perturbation, an explosion behind us, we are going to do this. And very simply, that tells you that it is your flexors that are neurologically set up to shorten. Your extensors are simply not set up to shorten. Let me give you a little example of that. You have a little muscle here on the midline of your cervical spine called rectus capitis posterior minor. I did a paper on this actually with some colleagues some years back, the myodural bridge. That small muscle, if we were to examine it from a histological viewpoint, it has somewhere in the region of about, I'm just going to round off the figures, but somewhere in the region of about 80,000 receptors. Now, if you compare that to your gluteus maximus has about 80, not 80,000, wow. 80. So these spindles, these receptors that are in your tissue, in this case, rectus capitis posterior minor is less of a muscle about moving your head. It does a couple of things, by the way. We did sheet plastinations with this muscle, and what we discovered, in fact, was that the fascial element of the muscle went right through to the dura. In fact, what we didn't include in the paper, but I can tell people, is we also saw these fascial extensions going through small foramen in the occipital bone, and also in running in continuity with the dura, and therefore the meninges. And so what's happening is that rectus capitis posterior minor is creating tension to ensure that the dura does not fold on itself, does not crinkle on itself. But secondly, what it's doing, and this is crucially important, it's giving feedback to you, the individual, as to where you are in time and space. And so for people who have forward head posture, these are individuals that maybe their friends would call them clumsy. They tend to bang their elbows into things because they're not able to actually accurately work out how far away the door is, or they miss things like a press that's open. And so they tend to bang into things, and they tend to get those things wrong. And so that's a crucial point for me, for instance, to share with your community today, that if for instance, you are, for people who might know about muscle energy techniques, I don't know if people will know those techniques, but if you do, there are individuals, there are therapists out there, and they'll take a limb and they'll get you to contract against a really high intensity resistance, 100%. You're wasting your time, because that's targeting type 2 fibers, and type 2 fibers do not shorten when stressed or when there's an insult. It's type 1 fibers that shorten. And therefore, it is actually a low intensity contraction, a very mild contraction that works in terms of solving this problem. It's down to pure neurophysiology, and you cannot know what you don't know. So come to the summit and get this information.
Get this information, because absolutely, it just makes so much sense that we did learn anatomy, we did learn physiology, but we were in second year medical school. And that was a long time ago. And although we keep up to date, I think we become quite focused on, protocols that we're taught and that we have to try and implement, and guidelines. And of course, we're dealing with, obviously, sometimes multiple issues and multiple trauma. And we're forgetting those basics that can absolutely change the path for a patient, as well as the treatment that you're implementing. So if we just step back and take that time to learn those gems, which I'm sure you're going to give us many, it will open our eyes to a whole new world, which is so exciting.
Well, my job is to be an academic, to be involved in, science. And then the one thing I never do, I say this when I travel the world, I never dumb things down. My job as an educator is to take complicated topics and then to be able to translate that into, easy to digest, words and vocabulary. I'm constantly spending my time, in toy shops, picking up things like, for example, this one here is the Hoberman sphere. The Hoberman sphere is so important for me in terms of being able to provide imagery for individuals. If you stop and think about a long breathing, look.
Yeah, absolutely.
So this is a multi-bar mechanism. It's not a levered mechanism in the classical sense. It's multi-bar. If you think about the bladder filling and then the bladder emptying, if you think about your stomach filling and your stomach emptying. So these type of aids, teaching aids, are absolutely amazing for me. I've millions of them, by the way, for teaching all sorts of anatomy and physiology and neurophysiology. And then people go away then with the images in their head. They can't wait to go to Amazon or somewhere else to purchase their own, so that they can then explain to patients. And that's really what it's about. It's about being able to explain in a simplistic way, and people get it. They really get it when they see it, and then they feel it when the therapist is working on them. And to me, that's amazing.
Well, it's so important because I think when we look at the books, we're seeing linear lines, whereas when you demonstrate and you're seeing something that is circumferential, and as you say, multifaceted and expands and contracts. It's a human being. It's not something in a book, which brings me.
Well, that's where the Hoverman sphere is particularly useful, because if I hold one steady, I'll hold the bottom one steady, but by pulling on it, the entire thing expands. Now that is what's happening in the human body. So yes, you could say, look, if you look at this point and this is point A, and over here somewhere is point B, it looks like as if that's a linear relationship, but that's not what's happening in the entire structure. The entire structure, is involved, and these are spiraling, helical motions that are occurring. And yes, you could say it goes from here to here, but that really is a very reductionist vision of the reality of what's happening.
So that's making me think that we should be including breath work in our work when we are working with the skin, because as you say, if you think about which points you're touching, if you're wanting to have an overall effect, and you include that breathing, am I on this right track? You might make a difference.
Absolutely, but no. The only thing I'm going to say to you is everything is attached to everything. Everything is continuous with everything. Now, again, I'll come back to hierarchy, and we can start looking at how important, is this versus this. For example, what would be the most important, a breath out or a breath in? Of course, if we don't breathe, we die. So breathing, of course, is paramount. But believe it or not, on a hierarchical basis, breathing out is actually more important than the breath in. But that's just a little bit academic. I won't get into that today. Breath touches every one of the trillions of cells that you have in the human body. Now, as humans, by the way, we really struggle with trying to understand anything past, I know that we can understand 1 million because, we have lottery tickets and people win a million, and you know that you can buy a house for that or something to that effect. But when it comes to the body and you start talking about hundreds of thousands, or if you're talking in terms of years, we can't get our head around the fact that there are trillions of cells in the human body. And here's a good one, by the way. I have a colleague of mine by the name of Dr. Neil Thies. He's in New York University. Absolutely fantastic pathologist. And I was giving a presentation, and as I do, I tell people that about 10% of your body is you, and the other 90% is not you. The other 90% is bacteria. And Neil heard me giving this presentation, and he emailed me and said, John, your figures are wrong. He said it's 1% you and 99% bacteria. Wow. Now, that type of figure just blows people away. It's hard to get your head around these facts that you're just 1% you, because you can feel this. You say, no, hang on a second. How could I? But for instance, you have bacteria that live here in the creases of your skin, and their job is to eat dead skin. And if you didn't have that bacteria, you would not be able to open and close your digits. So they're your friend. And we also have other bacteria that live, around our mouth and on our hands, Streptococcus, Steph's. Now, unfortunately, if they get into your upper respiratory tract, then you're going to get an infection. You're going to get a sore throat. Yeah. So they belong out here. They don't belong in there. We've other bacteria in there, H. pylori, and they belong in quantity in your stomach. But again, then if we let them run wild, you're going to have acid reflux. So it's amazing. We have this symbiotic relationship with all of these characters. Incidentally, we cannot digest sugars. Humans do not have the ability to digest sugars. Hence, we have bacteria that do it for us. It's a symbiotic relationship. We have, hopefully, if people come to the summit, if they participate, you're going to walk. I'm hoping you're going to walk away, certainly with the 40 years of my experience for what it's worth. And you can take it and integrate it into what you're doing. And, it's all science-based. It's based on sound anatomy and physiology. And I think that's unique, by the way, Robyn. Without blowing my own trumpet too much, I would say that I've spent my life as an exercise physiologist and an anatomist working in manual therapy, and certainly over my, would say, 40 years, I hadn't met another anatomist. One or two are now starting to come into the scene, but really for 35, 36 years, I was the only anatomist that I knew of that was also working in bodywork therapy. So, I can bring that, that unique experience. And then before I leave this blue planet, I'd love to be able to have the opportunity to share it with as many people as possible,
Absolutely. And we need you. I mean, that's just so incredible, is that you're able to, and passionate about imparting that knowledge,
Absolutely.
Passing on those clinical pearls. And I think for me as well, I've always wanted to do something that has global impact. And you can only really do that through collaboration. When we come together because of a shared interest and passion, you just don't know where it's going to go. And also, you then are able to impact so many more lives simply by touching the therapists that come to you to learn.
Well, that's something I'm particularly proud of, is the fact that you have an impact on people who go into their community, and that they're doing something that's really, really worthwhile, helping people to live happier, healthier, pain-free lives, and for them to thrive and enjoy their families.
Yeah.
And that's something that we need to do. We need to really stop and think about our lives. I think there's too much greed. We need to be happy with participating in our community and making sure that everybody is looked after. But this is a great career. It's a great way of making a living. It's very fulfilling. But there's a different story to be told. Believe me when I say to you that if you stop and think about, in terms of anatomy, if we were to stop and think about the first, airplane, like the Wright brothers, and look at the airplanes that we have today, stop and think about the first mode of communication, maybe smoke signals, or sending a pigeon out, or Bell inventing the telephone. And now we have these smartphones, and look at us, you and I are on Zoom here today. So things have really progressed and have advanced. Anatomy hasn't. We are still teaching the exact same anatomy today as was being taught in the 1700s, the exact same anatomy. Now, that to me just really doesn't add up. It doesn't stack up. That anatomy is done and dusted. We've had the last word and the only word on anatomy. Nothing to see here, move on. Really? That is just not the case. And we need a new set of explanations so that we have an anatomy fit for the 21st century. Come to the summit. Come on, guys.
But also, when we were chatting last week, you were telling me about how so much of the anatomy is just man-made terminology, origin and insertion.
Yeah.
Yeah. Tell us about what you think.
It's another one of my passions, and it's something I keep meaning to do. And unfortunately, I keep getting sidetracked. I really want to do a paper on women in anatomy, but yes, it was male dominated. And these are man-made terms. So when you think about, as I say, muscularis meaning little mice, okay, very nice. It's a nice history to look back and see, but from a physiology viewpoint, little mice, it really didn't help me in any way to understand what this tissue was, and it didn't inform me. Acetabulum, for your hip joint, means vinegar bowl. People might talk about the hippocampus in the brain. Hippocampus means sea monster or seahorse. And that's because if you cut everything else away but just leave that portion of brain, it looked like a seahorse. But it didn't tell you anything about its function or, its neurophysiology. So, and that's fantastic. I mean, these people looked at the human body based upon primarily influenced by René Descartes, because René Descartes was a horologist. He was very interested in clocks and watches, and he thought that you could explain living movement, animal movement, and human movement via mechanistic explanations, similar to the fine mechanisms in a clock, things, cams and so on, moving past each other. And he thought that he could explain that. And that's where he came up with, supporting this idea of levers, and levers are based upon what we call pin joints. In fact, I have one here. So this would be a pin joint, but you can see it requires a pin.
Yes.
Now, we do not have bones in the human body that overlap each other and then have a pin, running through them to secure them in place. If you see an X-ray of a knee joint, you'll see that there's a virtual space. There are no real spaces, but there's a virtual space between the tibia and the femur. And so this type of system just can't exist in the human body. It's not possible. Plus, if I let go of this, it falls. So this has to, of course, be attached somewhere up here to another portion and then attached somewhere else. So it can't be based on a 2-bar open chain kinematic system. It has to be a minimum of what we call 3 bars, and 3 bars provide you with stability, but then you have to add in a 4th bar to be able to give you motion and movement. And of course, human movement is predicated upon multiple bars, but not a pin joint, not a pin joint to be seen.
I love it. So goodbye levers.
So goodbye levers. Although it looks like a lever system, I grant you that it looks like a lever system, but we need to get our head around the fact that it is not a lever system. And therefore, what I would suggest to people is, where are you generating the forces that operate your upper limb? You're generating them in your lower limbs. And then your lower limbs share those forces through your torso to your upper limb. Now, if you don't have lower limbs, what do? Well, you're a human. You're a living tensegrity. You adapt. But the fact is, you do have lower limbs. So therefore, when we look at musculature in the upper limbs are like coracobrachialis or brachialis or brachioradialis. These are small muscles. In the scheme of things, they're small muscles, and they're about dexterity. They're about providing you with the opportunity of twisting and turning. They're not about producing large forces. And people go into gyms and they want to make these into lower limbs. They want to make them into legs. And the problem with that then is that they end up having shoulder injuries, and they wonder why, because pectoralis minor cannot deal with, you've made it bigger, so it can now produce more forces. But guess what you haven't done? You haven't actually increased the level of fascia. You've increased the fibers and the strength of the fibers, but those forces are shared into your connective tissue. So guess what your connective tissue does? It tears. Don't be surprised that it tears, because you're now producing, muscles that can produce more force than the fascial system can cope with. It's really easy.
Well, that's when you get popped bicep tendons, from guys that are in the gym and now they don't have.
The bicep is this size, and it generates huge forces, but the actual tendons can't cope with those forces. And the osteofascial tissue, your bone, it can't cope with those forces. These are modern man-made ideas, influenced by, movies. Because we like to see big muscles and also, of course, from the early Mr. Universe and all of those type of things. But that's not part of normal evolution.
It's also not sustainable. You can't sustain it, and it's not really a life, because you've got to constantly be in the gym building these muscles to maintain them. That what's going to happen in time.
Sure. Arnold Schwarzenegger himself has spoken about that, missed his own father's funeral, and, because he was too busy training, for Mr. Universe. And listen, I'm all on for democracy. We live in a democracy. So if somebody wants to do that, if that gives them pleasure in life, I say go for it. But I'm just saying, also be informed. Be informed that developing muscles that, in your arm that really belong in the leg. There's a price to pay for that. There's a consequence for that. So that when it happens to you, don't be surprised. You have to be informed.
Absolutely. Can we talk a little bit about fascia? It's a fairly new concept for me to be. I understand academically that our fascia is continuous. It's an entire system. It's integrated. and what's happening all over the body is connected, and therefore our treatment needs to be holistic, and we need to step back and zoom out and look at our patients. But I think that as therapists, our knowledge of this is fairly limited, depending on how deep you've dived into it, of course. But what are you going to teach us at the summit about fascia? And what would you say is a key thing for therapists to learn?
Okay, so I'm going to try to teach a plethora of things if I can. I mean, I've got to pull at the reins with myself because of the limitation of time, and I also need to do an introduction, because if I go too fast and if I try to come in too high, I will lose people. But for example, you can feel a tendon just there. This is my biceps, my big biceps brachii, and then in my case, because of my somatotype, I can fit two fingers in there where I'm feeling a tendon. So that's the tendon there of my biceps. Well, if I was to dissect the skin here and I was to retract it back, you'd actually see this flimsy tissue here. It looks very like a mucus. And you think to yourself, well, hang on a second, what's that doing there? I can understand the tendon. The tendon is about the muscle fibers have this fantastic ability to create forces. We call that contraction, meaning to shrink. Anyway, they create forces, which are pulling forces. And those forces are shared into the fascial net, into the fascial system. And tendons can they're really strong, and they can facilitate those forces. That makes good sense. But what's this flimsy thing doing down here? Or for instance, we look at retinacula in the body. What are the retinacula about? These are what we call flat tendons. Well, it turns out a couple of things. First of all, if I do a dissection here, what you'll see if I open up the forearm is that the muscle fibers are directly integrated into the fascia, which means that when these muscle fibers contract, they're pulling on the fascia and they're sharing those forces through the fascial system. So there is no such thing as agonist-antagonist. That doesn't exist. They're all playing a role in sharing the forces. But then when you come down to this portion of my forearm, when I open up the fascia, you find that the fascia is not connected to the tendons. So the tendons are in fact running under the fascia. And what do they need to do? They need to, now, by the way, I'm using a word today, and I'd love to ask your community, can you come up with a better word for me? I'm going to use the word glide, but I'm not tremendously happy with glide. I will say that there's no sliding in the human body. So if people place their hands together and do this, they'll feel heat, and the heat is a consequence of friction. So that only happens in the human body when you have pathology, and we don't want pathology. So we want to make sure that tissues are gliding naturally. And this happens, partially because of something called hyaluron. So basically, there's no friction. Those tissues are not touching each other, but yet they're being facilitated. They're facilitating motion and movement, but they wouldn't be able to do that if they were attached to each other. So what often happens, for instance, in this area, is that these tissues become adhered. And so in order to be able to maintain normal motion of the hand, one might have to do some specific therapeutic intervention to restore that normal gliding of the tissues. So there's a perfect example then, understanding the role that fascia plays in different locations in the body. And by being able to understand that and appreciating that, you can then bring the right tools to the table and the right therapeutic interventions.
And why do you think that, is it just with age that our skin becomes attached, and you can see those folds and you can see that lack of movement?
Absolutely. So if I bring my wrist closer to the camera, and if I do that, you can see those folds, those lines. So what's happening specifically at those lines is that the fascia is tacked down, it is adhered, and therefore the skin moves around them. So now they actually begin to act like joints. They begin to act like skin. They are skin joints. Okay. You can see them in there. in the forehead as well. You see them in the brow. So this is what's happening now. People are amazed by the human body, and absolutely, I agree with you completely from an evolutionary viewpoint. If I was making you, I'd have made you different. I'd have made our eyeballs differently. I'd have provided us with the ability to be able to see at nighttime, and perhaps maybe to be able to see in, infrared and ultraviolet, and maybe even in X-ray. It would have been fantastic to be able to look through a wall and see something behind it. A lioness can see at nighttime, can see prey, and can, what other animals can't see them. So, we have what we have from an evolutionary viewpoint, and that's because there were changes occurring on the Earth very fast, and those species that were able to adapt quickly, they were able to, continue on living, and others who didn't adapt quickly became extinct. So those changes that happened very quickly, they weren't always perfect manifestations, but they were good enough to get us, another 100,000 years or 200,000 years down the road. So we age. Scientists do not know why we age. Scientists do not know why cells have apoptosis, why we have cell death. And of course, there are some people who would like to cheat death and have their heads and their bodies placed in cryotherapy in the hope that in years to come, they'll be able to maybe stitch them onto a 21-year-old body. Walt Disney did that, but unfortunately there was a problem at the center that his head was stored in, and unfortunately the cryotherapy didn't work. But people really want to do this. So we age. That's just, I'm quite happy with it. One lifetime, I think, is enough for me, and I'll be ready to, move on. I'll say goodbye and I'll miss everybody, but, I don't think I'd want to live forever anyway. So, there's a beauty in as I was saying the other day, somebody has a little crooked tooth and they want to get it fixed, but that crooked tooth could be the very reason that somebody fell in love with you. So the imperfection is in many cases what makes it perfect. Yeah. So we do have imperfections in human physiology and human anatomy, but perhaps that's what's so beautiful about us.
Yeah, absolutely. It is a beautiful thing, I must say. I've been listening to David Schmidt a lot, and he was just, been studying why we age. And he was just saying it has so much to do with the ability of the mitochondria to function effectively, for the cell to detox, for free radicals to be fired out, and for the cell to have that speed at which it's growing and metabolizing. That makes it feel younger. But when things become sluggish and they slow down, then everything ages. But we can reverse that just by getting the cells to think that they're to think that they are younger. So there's some interesting technology out there, but as you say, it's whether or not you want to live to 200. We're happy with one lifetime, and to be able to contribute and to pursue our passions.
Well, as I say, the aging process is something that we have to deal with. And I know that people would love to be able to, exercise at the right level and intensities to try to keep old age at bay. And but the facts of the matter are, I promise you, when you hit 50, for example, you have to go down a gear. And you can't pretend that you're a 20-year-old at 50. In fact, if you want to have longevity, I think the secret is about ensuring that actually, this is a major point for us now to make, Robyn. Okay. I would say that the most frequent reason for people coming to the clinic and seeing you because they're in pain, or because they had an injury, or because is under recovery. In exercise science, they'd call it overtraining or staleness. But people are just doing far too much in terms of their exercise, although we'd have other people at the other end of that spectrum who aren't doing any physical activity, and we'd love to pull them into it. But just mums and dads, for example, having to, do a full day's work, get home from work, bring the kids to karate, bring them to swimming, then they have to get back home, help them with their homework, make their sandwiches or whatever for the next day in school, change the bed sheets, clean up that. My God, there's no end to it for these people. Yeah. And that is a huge part of it, is lack of recovery. It really is.
Absolutely. And the same with athletic sportsmen. I mean, I know in my rehab, if I say to somebody, really what you should do is rest for 2 weeks and let this treatment work, I've learned you can't tell that to a sportsman. They're not going to listen. They're going to get right back there, and they will find somebody who will let them carry on. So
yeah, I think the best thing to do is if you can give them advice to say, look, what I'd like you to do is I'd like you to reduce the intensity of this particular, activity by 30%. Maybe what we'll do is we'll substitute that with some stationary cycling just for the next 2 weeks. Now, they may go along with something like that, but that's the nature of the athlete. They'll stand in front of you and say, great, Robyn, I'll do exactly as you told me to do. Yeah. And they won't. Right?
Well, you worked with Olympic athletes, and you can't get more elite than that. So the psychology, and I've certainly learned that in my practice. I'd rather work with that person to achieve their goals than to stop them. You just can't. You're fooling yourself.
For sure. Well, that's also an ethical situation where you might have somebody coming to you who's a gymnast and they need excessive range of motion, and you have to say to yourself, well, excessive range of motion, once again, as I often say to people, there are no free meals, no free dinners in life. There is a price to pay for every single thing you do, even the good things that you do, even the healthy things. And this is why I'm saying people need to be informed. If you are informed, then you make informed choices. Mm-hmm. So, any type of exercise, there's a price to pay. In other words, a currency where you're going to have to hand something out, some kind of currency, whether it's wear and tear or whatever you wish to call it. So, for instance, your heart. Here we have a heart, and your heart is beating. Well, your heart has a certain number of beats, and then that's it. And you don't know how many beats your heart has. Yeah. So when you exercise, you increase the number of heartbeats. So you're spending heartbeats. Wow. Is that a good thing? Well, you see, the idea would be that if I spend out those heartbeats now, that when I finish my exercise, my heart will actually beat slower when I'm at rest, which means I'm actually giving out a less amount of heartbeats over the duration of the day. So therefore, I'm actually going to be saving on heartbeats, you see? Yeah. And that would be the premise of why you should, do exercise, you see? Incidentally, by the way, this is a heart. And when I was first starting anatomy, we were told that hearts beat like this, bum, 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 bum. Yes? I'm not going to get into this in any great detail. That's not how the heart beats. So your heart is in fact a spiral. And I was given this heart from the son of a cardiac specialist, Dr. Torrance Wasp, who unfortunately died of a heart attack. But he spent his life trying to investigate the true anatomy of the heart. The true anatomy of the heart escaped Vesalius, Galen, and Leonardo da Vinci, and several other pantheons of anatomy. They knew that the heart was spiraled, but they couldn't figure it out. But Dr. Torrance Wasp did. And so this is a model of the dissection that we do. And so if I show you how the heart actually forms, that's how the heart forms in embryology. And then what it does is it spirals into being that you have your upper atria and your lower ventricle. And so this is the true anatomy of the heart. And what the heart in fact does is it spirals. So this is how it contracts. Okay. Not like this, not like that, but like this. Isn't that amazing?
That is amazing.
So, anatomy is not done and dusted. We have not had the last word in anatomy. We need anatomy for the 21st century. So please come along and help me. Help me to make this paradigm shift. Help me to be part of the revolution in South Africa and across the world, North America, and everywhere. Let's get this revolution going.
John, I think what you have done for me is just brought back that feeling of I have so much to learn, which I love, because when we feel we know it all, that's when we're in trouble. And also just to have a fresh perspective, look at my patients with completely fresh eyes and start thinking about treatment differently. And so I'm incredibly grateful to you for for giving us your time in the summit, and for letting us then digest that information and come back and do a Q&A. That's extremely generous of you. Thank you very, very much.
Well, I'm thrilled to do it, Robyn. It's amazing people don't stop to think about individuals like yourself who take on the responsibility of running something like this. It can be frightening, and at the same time, I don't know why, but it's addictive. You could lose your shirt on it and you'll still want to do it again next year. I don't know why that is, but there's the motivation, something special about just, bringing people together and sharing, new ideas, a new vision, with the, surgeons and with the therapists, and also to help bring, the medically qualified specialist and the manual therapist, and bringing them together. That's a really important thing to do, and I applaud you for your efforts.
Thank you. Yes, I actually wrote a LinkedIn post where I said I had this burning desire within me to do this, and I couldn't stop. There's no way I could not do it. And I had this vision, and I suppose it is exactly that. It's the idea of the practical learning, the collaboration, the bringing great minds together for conversation, which is why I've done these interviews as well. I think it's so important to just listen to conversation because you learn so much. And then the standalone entrepreneur day, because that's open to everybody. But also I feel that within all of us, there is that little budding entrepreneur. And so just to be able to also give us a little bit of a mental breather, to listen to different people have different ideas, use a different side of our brain, and maybe ignite something in somebody somewhere. So it's nice to know that you see the value. Thank you.
Sure. And then I see people, talking about Instagram and TikTok and so on, and like these 30-second, 60-second. Our community are committed to helping people in pain to move better. They love these kind of conversations, and they will invest in them. They will come and they will invest, and you should be investing. You should be investing in your knowledge, in your clinic. So yeah, come and join the clinic, or come and join the summit, and let's share the information. We share the love. That's what we need more of as well.
Share the love. And I'm sure we won't stop there, John. I'm sure that it's just going to open so many doors, and I look forward to welcoming you to South Africa.
Oh yeah, of course. We've got the dissection course next year. Hopefully we'll share information about that so that people will come and spend time learning more about fascia and living tensegrity. It was great talking with you, Rob.
Thank you very much.